Okay, so in this video we'll be having a look at a dorsipalmar or PA wrist projection and a lateral wrist projection. So we can see this time we've got Josh as our patient sitting at the end of the bed, again with his legs out of the way from underneath the bed. Sam's just placing some gonadal shielding there, which is best practice. It would be good to see the table go up a little bit more just for Sam's comfort and for the patient. Table up a little bit here. And what we really need is the elbow at about 90 degrees and the elbow and wrist and hand all at the same level on the table, and the table at a height where the patient is nice and comfortable. We just want the hand flat on the image receptor, that the kind of the hand and wrist as flat as possible. Again, with a patient with a sore wrist, they may not be able to do that as much as you would like. Sam's just bringing the tube in, so we want to be centered at the wrist joint, kind of using the styloid processes of the radius and ulna as a guide. We've got our source image distance at 100 centimeters there. And if we just have a bit of a closer look, we've got the kind of long axis of the forearm, if you like, kind of in line with the image receptor, so everything's nice and straight and nice and central on the image receptor. There's our centering point in between the styloid processes at the wrist joint. Our collimation is going to include the distal third of the radius and ulna. We want to be including all the carpal bones. You don't need to have the whole metacarpal bones on. Something like Sam's demonstrating there is perfect. And just have the skin margins on laterally immediately with our marker in the field of view as well. Okay, so once that projection is taken, we can talk about the lateral projection. So here we're just going to bring the lateral part of the wrist up onto the image receptor, and you can see Sam just bending the thumb forward a little bit there, so it's not overlapping any important anatomy. Otherwise, we've got a very similar patient position with the elbow, wrist and hand all lined up nice and straight with the image receptor. If we have a closer look at the positioning, we can see that as Sam moves the wrist up onto the side, he'll be feeling the posterior of the wrist, looking for the styloid processes, trying to palpate those and just trying to get that radius and ulna superimposed. Often the hand actually looks a little bit externally rotated in order to get the wrist in a true lateral position. So if we were doing this on a CR system, we'd be using a 24 by 30 image receptor, and in some cases you might be able to do it on an 18 by 24, an even smaller size image receptor. That's our lateral projection taken there. A couple of extras, so our exposure factors, KVP is going to be 55 to 60 KVP. MAS is again quite low at 2 to 3 MAS, and we will be using fine focus because we need to see maximum resolution for looking for subtle fractures in our distal radius and ulna, and no grid is necessary. Okay, once again, Jenny and Pam 1015 will talk a bit more about the radiographic appearances and the radiographic anatomy specifically.